I want to take a moment to discuss a bit of elementary anatomy with you regarding the position of the heart and the chest. One would think that there would be no need for a topic so simple to be discussed with you participants here in the Advanced ECG Interpretation Boot Camp. But it's a topic that managed to elude some of the best minds in electrocardiography for over 50 years, and probably even longer. That's because we all like to simplify things in order to understand them better. There's certainly no harm in that. I do it all the time. But we must be careful not to let our simplifications become oversimplifications and eventually frank misinformation. We think of the heart and each chamber of the heart more as a box rather than a section of a cone. We think of anterior and posterior surfaces, superior and inferior surfaces, and right and left lateral surfaces. None of these sides exists in a living heart. Here's where our simplifications become somewhat treacherous and misleading. The anterior surface of the heart may be the superior surface in one sense, but it's also the interventricular septum in another sense. What we've always thought of as the posterior surface of the left ventricle is really the left lateral surface of the left ventricle. Back in 1964, Dr. Joseph K. Perloff wrote a very important and groundbreaking paper titled "The Recognition of Strictly Posterior Myocardial Infarction by Conventional Scalar Electrocardiography." Conventional scalar electrocardiography simply means standard 12-lead ECG. Dr. Perloff said that it was indeed possible to diagnose an acute infarction in the posterior wall of the heart on a standard 12-lead ECG. Bear in mind that up until 1964, no one thought that was possible. Much of his article still holds true today, though some of his interpretations of his own observations have been proved wrong. Dr. Perloff stated that an acute posterior infarction could be recognized on the 12-lead ECG by finding ST depression, usually a flat ST depression, in leads V1 through V3, along with R waves larger than expected for those leads and upright T waves in those leads. The first thing that was discovered to be wrong was the location of the infarction. Even prior to 1964, we knew about placing electrodes on the posterior chest wall to acquire the posterior chest leads V7, V8, V9. Now, here comes the interesting part. It was just assumed that since they were located on the posterior chest wall, that they would be recording the posterior wall of the left ventricle. It was intuitive, and it just seemed to make sense. What many failed to consider, and for 50 years they failed to consider this, was that those posterior leads were simply recording the events in whichever part of the heart was located directly beneath them. It was a simple fact that there was no real reason the posterior wall of the heart had to be facing the posterior wall of the chest. That's analogous to saying that a fetus in utero must be facing forward because the mother is facing forward. Pathologists and anatomists and even radiologists tried explaining this to us for years, but no one would listen. Dr. Perloff viewed the heart, as did most others, in what today we call the Valentine position. This is the Valentine position. Does it look a little familiar? We use the term Valentine position in the pejorative sense. To say that someone based an analysis of the heart in the Valentine position is not a compliment, but usually precedes some rather sharp criticism. Only in the Valentine position do we see the left anterior descending artery, and that's this red vessel running along here. This is the left anterior descending artery, the LAD, and it's running down the center of the heart. Now, we only see this when the heart is being illustrated in the Valentine position. Now, the interventricular septum does indeed lie just below the left anterior descending artery, and if we could see it directly in this view, we'd be looking at the top of the septum end on. Now, when the heart is illustrated in its real anatomic position, we don't see this. You'll see a number of right coronary artery branches, these right here, and the distal part of the left anterior descending artery, which is this part right here. But you don't see the LAD, the left anterior descending artery, coursing down the middle of the heart. Again, this is the right coronary artery, not the LAD. Now, let's rotate back to the Valentine position. Just be aware that when you see the heart in the Valentine position is showing you the left lateral surface of the heart. Let me repeat that. The Valentine position is showing you the left lateral surface of the heart. Right ventricle, left ventricle. This is the left lateral surface of the left ventricle and overall the left lateral surface of the heart. The ventricles are not right-left structures. They're actually anterior-posterior structures. This is the right ventricle, left ventricle. This is the anterior orientation, posterior orientation. The right ventricle is anterior to the left ventricle. It is not really to the right of it except by just a slight amount. They should have been called anterior ventricle and posterior ventricle. So when you see the heart positioned so that the right ventricle is on the right and the left ventricle is on the left, and you know this because they're separated by the left anterior descending artery running down the middle of the heart here at this view, then you could only be visualizing this view from a left lateral perspective. Now, in the Valentine position, the right atrium and right ventricle are on the right, to the right of the left anterior descending artery. The left atrium and left ventricle are on the left of the left anterior descending artery. The atria are located above their respective ventricles. That is not a normal location for them. Now, we're going to rotate the heart a little bit further to the left so you can see a little bit more of the left lateral wall. This is the left lateral wall of the left ventricle, or the lateral wall of the left ventricle. Now, I want you to focus on this area a little bit because we're going to do something in just a moment. I do want to point out that this area right up here is what we used to call the high lateral area of the left ventricle. Nowadays we call it the basal lateral area of the left ventricle. That refers to the base of the heart. The base of the heart is this portion of the heart that separates the atria from the ventricles. It's the plane where the aortic valve and the tricuspid and mitral valves are located, but it is separating the atria from the ventricles. That's opposed by the apex down here on the opposite end of the heart. This is the apex. This is the base. Apex. Now again, I want you to remember this area right here. This is the lateral border of the left ventricle. I'm going to rotate the heart back to its normal anatomic location. Okay. Where's the lateral wall of the left ventricle now? It's located posteriorly, isn't it? So what we always thought of as a posterior infarction, which we felt we could prove with ST elevations and leads V7, V8, V9, is actually an infarction of the lateral wall of the left ventricle. Posterior infarctions are lateral wall infarctions. Now, you may ask, isn't there a real posterior surface of the left ventricle? And if there is, can't it infarct also? Well, in some people, the area of the inferior wall angles up as it gets close to the posterior basal area of the left ventricle. This is what was always thought of as the true posterior area. We now know that such an area is simply not present in many, if not most people. But, of course, if it's myocardium, it can infarct. It should be apparent to you now that due to the real anatomical position of the heart, the one you see it in right now, this posterior basal area is actually located more to the right than posteriorly. So when ischemia occurs in this area, the ischemic vector is going to point directly opposite to the area somewhere between leads V3 and V4, probably closer to V4. Remember, in infarction, the injury vector is going to point to the infarction, to the area of ischemia. So what you would see would be the negative end of that vector coming out between leads V3 and V4. Now, the posterior basal area is one of the last areas to be reached by the wave of depolarization. Because there is no impulse there during the first 40 milliseconds of ventricular depolarization, and by ventricular depolarization we mean QRS complex, no Q wave is going to be inscribed. A true posterior infarction will be hidden within the QRS complexes of leads V3 and V4, presenting as notching or nonspecific widening of the QRS complexes. Another erroneous concept based on the Valentine position of the heart was that if you looked at the heart in the frontal plane, you'd be looking at the top of the septum end on. Indeed, that would be the case if the heart truly were in the Valentine position. The septum underlies the left anterior descending artery here, so if we were looking at it from this perspective, we would be looking directly at the top of the interventricular septum end on. But again, this is the Valentine position. This is not the position the heart is actually in. This is the position the heart is actually in. So with the heart in the true anatomic location in the frontal plane, you'd be viewing the septum from its right side. Now this leads us to the question, what constitutes the anterior wall of the left ventricle? The answer should be obvious by now. The interventricular septum is the anterior wall of the left ventricle. The great cardiologist and electrocardiographer Leo Shamroth pointed that out years ago in his textbooks. So, to summarize, first, the lateral wall of the left ventricle is located posteriorly in the chest. Now, while admittedly it is not the posterior wall of the heart, it is the surface that is located beneath the electrodes for leads V7, V8, and V9. And second, the interventricular septum is almost parallel to the frontal plane. These are concepts that may take a while to assimilate, but you will. Sometimes when we see things on an ECG that just don't seem to make any sense, it's often because we're thinking of the heart in the Valentine position rather than the actual anatomic position. Now we'll return to the live portion of this lesson, and I'll be glad to answer any questions you may have.